Okay, so we left off on Thursday. We finished up with the axial skeleton, and today we'll finish up with the appendicular skeleton. So these are the bones in all of your appendages, and this will be a good kind of correlation with lab, because in lab today we'll be doing all appendicular skeleton as well. So that's kind of what today is. So if we start by looking at the appendicular skeleton, we look at the bones of the pectoral girdle first. And this includes your scapula, which is your shoulder blade, and your clavicle, which is your collarbone. And sometimes it helps to feel on your body where these bones are. Don't dig too deeply, but just, so you can visualize and connect them to where they are on you. So here's the pectoral girdle. It connects your arm bones to your thoracic cage. So here you can see the clavicle and the scapula that make up the pectoral girdle, and how the scapula will connect to the humerus. The head of the humerus sits right in that ball and socket joint. And then the rest of the upper limb includes the radius, the ulna, the carpal bones are in the wrist, the metacarpals are in your, the palms of your hand, and the phalanges are your digits. So if we look at the upper limb, the radius and ulna, the radius, it will always be the bone on the lateral side in anatomical position. So if you guys stand in anatomical position and put your arms by your sides with the palms facing forward, the radius will always be the bone on the lateral side of your forearm, and it will always line up with your thumb. The radius and ulna will crisscross each other when you move your forearms to the front and back. But this is the upper limb, and again, focusing on the pectoral girdle, your clavicle and scapula are there. So here are different parts of the scapula and clavicle, and they're all labeled here. A lot of this is learning the anatomy, kind of like the bones of your skull, the bones of your thoracic cage. The scapula and clavicle have other bone markings that are important to learn. If we look at the posterior side of the scapula, here's the spine of the scapula, and you can all feel that spine in your back. And the spine ends up on this bony acromion process. And if you feel your shoulders, you can feel the bump on the top of your shoulders. You're feeling that acromion process. The scapula has borders to it. This is the medial border. It'll be closer to the midline. The lateral border will be further on the lateral side. And then you have a fossa, are depressions. A supraspinous fossa is a depression above the spine. The infraspinous fossa is below the spine. And if you look at an anterior view of the scapula, so looking at it from the front, it has a subscapular fossa on the front side of the scapula. Also shown below, yeah, I'll mute everybody. Okay, hopefully that's a little better. So there is your clavicle, and there's a distal and a proximal end to the clavicle. The proximal end will be what attaches to your sternum. And those are the main markings on the scapula and clavicle. Here are the upper limb bones, and this kind of gives you the anatomical name for the upper limb bones, and then the more generic term. So the ulna and radius are in your forearm, the humerus is in your upper limb, and the carpals and metacarpals are listed there. And this is, again, picturing the upper limb bones for you. And here is the humerus and some major features of the humerus. The head of the humerus will be kind of the smooth rounded part that will articulate with your scapula. And there will be an anatomical neck that surrounds the head and a surgical neck that's a little bit lower. The greater and lesser tubercle refer to bumps on the anterior side of the humerus. So this greater tubercle will be on the lateral side, and the lesser tubercle is on the anterior side of the humerus. And again, a tubercle is just a small bony bump on the anterior side of that humerus. If we work our way down, there's a little raised bump on the humerus called the deltoid tuberosity. It's really hard to detect, but the deltoid tuberosity is important because it'll be the place where your deltoid muscle attaches onto the humerus bone. Your deltoid muscle is your muscle that goes over your shoulder. It's shaped like a triangle, and I have like no muscles in my arms, but if you can kind of feel where your deltoid muscle ends, you'll feel that place where it ends is where it's attaching to that deltoid tuberosity. And then at the distal or bottom end of the humerus, we have epicondyles, which are rounded bumps on the sides of it, the lateral epicondyle and the medial epicondyle. The medial epicondyle, if you feel the inside of your elbow, you'll feel a bump. Some people call it the funny bone. You're actually touching your medial epicondyle on the inside of your elbow. You don't have a funny bone. When you bang your elbow down and you get a jarring pain, you're actually you're slamming one of the nerves in your arm, but we've nicknamed that jarring pain hitting your funny bone. But that medial epicondyle is that medial bone. There's more condyles. The capitulum, the trochlea are rounded condyles at the base of the humerus, and on the back, you can see where the trochlea kind of brings its way to the back. And there's another tiny fossa called the olecranon fossa on the back side of the humerus. That will be where your ulna bone connects to make your elbow joint that bends your arms. This will be basically what we do in lab today too. So you'll hear this probably again with me in lab. So if you have questions on it now, I know there's going to be a lot of information right now. If we look at your radius and ulna, again, these are the bones in your forearm. The radius will always line up with your thumb, and the radius has a structure at the top of it called the head. And if any of you guys play golf, the head kind of looks like a golf tee that you would set a golf ball on. I play mini golf, that's about it. But they tell me the head of the radius looks like a golf tee. So that will hopefully help you there. The radial tuberosity is a bump that sticks out from the radius. Here's the radius shaft, and then the styloid process is a little tiny bump that juts out at the bottom of the radius. The ulna then will have an olecranon process. That's just the piece that sticks up with the trochlear notch, which will kind of match into that trochlea part of the humerus. And then here's the ulna, and the styloid process is down there. So that's the ulna and the radius. Here are the bones of the wrist and the hand. Your carpal bones, you have 8 of them, kind of in 2 rows. These are the bones of your wrist. We'll figure out in lab if you need to know all of them in order. You probably will need to know all these bones in the wrist. The metacarpal bones are just the bones in the palm of your hand, and then the digits are the phalanges. You have a proximal, middle, and distal phalange, depending on what part of the digit it's referring to, and there will be a joint in between each phalanx or each phalange. The thumb just has a proximal and distal phalanx or phalange, and that's because your thumb only bends in 2 spots, so it just has a proximal and a distal phalange, whereas your fingers all bend in 3 spots, so that's why there's a proximal, middle, and a distal phalanx in each of your 4 digits there. Okay, we'll go over the carpal bones a little more in detail in lab when we get there too. All right, then moving to the pelvic girdle. Any questions so far on the pectoral girdle and the upper limb? Learning the bones is probably one of the hardest parts of anatomy, so there's just going to be a lot of information. That's why in lab today, this is all we're doing, and I just expect you guys to spend time working on the virtual lab, practicing those.
Hey, Professor, I got a off-the-wall question. Is it possible to have a 6-digit on your hand and the bones be able to function normally?
Yeah, so some people are born with 6 digits. That's actually really common in communities where there's some like intermarriage or having kids with close relatives. That's common to have extra digits. And I think people can, normally use them all. It might not be super helpful in some areas, like it might get in the way sometimes, but yeah, that is common to have a 6-digit, specifically in communities that intermarry or have relations with, and kids with people who are closely related to you. So that's one thing I wouldn't recommend.
Awesome.
because
Good to know.
60,
Yeah,
yeah.
I saw a video online and the little kid had 6 digit and he was able to function his hand
Oh,
normally.
yeah.
So I was like, can I please see an x-ray, please?
Yeah, it is possible.
uh,
Give me like 2 seconds, guys. A baby's crying. I'm just gonna lift him up. All right, so I'm back here with a child, which probably won't be uncommon as we keep going. Yeah, any other questions? That's a good one. Okay, so moving on to the pelvic girdle, and the pelvic girdle is what will attach the lower limbs to the rest of the body. It includes the pelvis, which includes the pelvic girdle, and the coccyx, which is your tailbone. And then the ischium and ilium bones are two other bones associated with that kind of hip bone. And the acetabulum is the hip socket or joint. Thanks, Melinda. Yeah, he is cute. Okay, so let's take a look. So here is your pelvis, and your pelvis consists of the hip bone. And the hip bone is made up of 3 separate bones that fuse together. So the ilium is shown up here, and then the pubis and the ischium are the 2 bones at the bottom. The pubis will be the bone in the front part of the hip bone, and the ischium is the bone in the back. The pelvis itself also includes the sacrum and coccyx in its description. Even though we learned about the sacrum and coccyx as part of your vertebral column in the axial skeleton, the sacrum and coccyx are included when we talk about the entire pelvis structure. So here is, I guess we'll kind of go, I think, into detail, yeah, separately as we take it apart. But your hip bone itself, the ilium, pubis, and ischium are all fused together in this location called the acetabulum. And this part where my cursor is, that's the place where the head of your femur will attach to your hip bone that forms the ball and socket joint of the hip. That is the place where these 3 bones will fuse together. And it's usually the most common site of breakage. You know, if someone, usually an elderly person, falls and breaks their hip, it might be some sort of cracking in this joint area. So now we're going to look at the hip bones separated out. So you have 2 hip bones that come together and are joined in the front at the pubis. And you'll see that here. So the 2 hip bones are joined at the front by the pubis. But if we separate out the hip bone into its 3 separate bones, in green, you see the ilium, the ischium is in orange, and the pubis is in blue. There will be a hole, a circular hole, and this is the obturator foramen, and you'll have different obturator blood vessels or nerves that go through that hole. Here is the acetabulum, which is just the socket to the ball and socket type joint. You'll have different parts and markings on this hip bone. The iliac crest, you can kind of feel your iliac crest if you dig into your back. It's the kind of the upper portion of that ilium bone. What else? The ischial tuberosity is a big bump on the ischium bone. Sometimes they call that the butt. So you're all sitting on your ischial tuberosities right now. That's the bone that you're sitting on and the bone marking. What else? This pubic symphysis is fibrocartilage that will soften and separate during labor and delivery to allow for a greater angle for a baby to get through. Comes back together, but that will separate. What else? We'll talk a little bit about here. So if you come across a dead body in the woods, or a skeleton in the woods, one place that medical examiners will help to identify gender is to look at the subpubic angle of the pelvis. And that's the angle between the pubis bones at the front. Females have a wider subpubic angle for childbearing purposes. Males are more narrow. Also, you can see some other differences looking at the pelvis. This describes some of the pelvic inlet is shown in red. You can see the pelvic brim is just an area where a child were to go through if you are female. Also, the iliums are more like kind of fan-shaped. They're wider in females as well. So usually the 2 places that medical examiners will look at a skeleton are the pelvis, but also the face. There's facial features that can determine male and female. This is a look at the female medial view and looking how the differences in the pelvic inlet and outlet, they're just the spaces going into and out of the pelvis, will differ between male and female pelvises. Okay, so that's the pelvis. Questions about that? Okay. So then into the lower limb, we have the femur, which is in your thigh, the patella is the kneecap, and then the tibia and fibula are two parallel legs or bones in the lower leg. The tibia is the larger of the two, and the fibula is the flimsy one. So fibula is flimsy, it's the smaller one. Tarsals are in the ankle, like your carpals are the wrist bones. Metatarsals are in the foot, or the sole of the foot, and then the phalanges are the toes and also fingers. So this is a look at the lower limb, the pelvic girdle, the hip. Here's your femur, patella. The tibia will connect to the femur, and then the fibula is just a much flimsier bone on the lateral side of the lower leg. You want the tibia, the larger of the two lower leg bones, to be in the medial side, closer to the midline, to help support the majority of your weight. And you can see the tarsal bones are the ankle bones, metatarsals, and the phalanges are your digits. Bones of the thigh, here is your femur. You have the head of the femur, a neck, and then you have trochanters, greater and lesser, which are large bony prominences or bumps. You can see the greater trochanter is on the lateral side, the lesser trochanter is on the medial posterior side of the femur. Condyles are shown here. These condyles will articulate with the tibia. They'll be covered with cartilage so that to reduce friction between bones. You'll have a patellar groove where the patella will sit, and that's your kneecap. The body of the femur, and then the linea aspera is kind of a raised line on the posterior side of the femur as well. So these are the bones of the thigh and some of their bone markings. The bones of the leg, the lower leg, the tibia will have lateral and medial condyles, which will line up with the lateral and medial condyles, again, rounded parts of the femur. The fibula is flimsy, the tibia is more sturdy. And then at the bottom of the fibula and tibia, you have a lateral malleolus and a medial malleolus. And the malleolus sometimes are known as your ankle bone. So if you feel the bottom or your ankle right now, you can feel the medial malleolus on the inside of your ankle. It's that bump you feel on your ankle, and you can also feel the lateral malleolus. That's the sharp kind of bump on the lateral side of your ankle. So that's what you're touching, is those medial and lateral malleoluses. The head of the fibula kind of articulates with that lateral condyle on the tibia. And these are the bones of the leg. They'll be connected with what we call an interosseous membrane. So there's just some tissue, connective tissue, that keeps them close together so they can't be separated easily. The bones of the foot, your tarsal bones, you have 7 tarsal bones. Maybe we'll look at the medial view first. The calcaneus is your heel bone, and the talus is the bone that will articulate with your tibia. So the tibia and the talus touch each other. And then if we look at a superior view, here's your navicular. Your cuboid tarsal bone is shaped kind of like a cube. And then you have a lateral, intermediate, and medial cuneiform bone that will articulate all with the navicular. And then the metatarsals are shown here in the sole of the foot. And then you have proximal, middle, and distal phalanges or phalanxes as a part of your digits. And again, just like your thumb, your big toe only bends in 2 places. So like the thumb, your big toe only has a proximal and distal phalanx, but the other 4 toes have proximal, middle, and distal phalanxes. And that gets us through this, the appendicular skeleton. Any questions on that before we talk about articulations, which are just joints? Okay, so articulations is another word for joints, and this will take us through and finish up this chapter. These are where two bones come together. Joints can be structurally classified as a fibrous joint, cartilaginous joint, or synovial joint, according to what connective tissue type will bind the bones together, and whether a fluid-filled joint capsule is present. Joints can also be classified into functional categories according to their degree of motion, as a synarthrosis, amphiarthrosis, or diarthrosis. And we'll talk about what those mean. So structural classifications, they can be fibrous joints. They are united by a fibrous connective tissue. And the classes of fibrous joints will be sutures, like the sutures that connect your skull bones together, syndesmoses, which are between the forearm bones, your radius and ulna, and your tibia and fibula, and your gomphoses, which a gomphoses joint is a joint where your teeth connect to the bones of your skull. Cartilaginous joints are united by cartilage. They can be synchondroses or symphyses. The pubic symphysis that connects your two pubis bones together is a cartilaginous joint. And a synovial joint is just a joint that's joined by a fluid-filled cavity. And these will be most joints of your appendicular skeleton. They're all synovial joints, meaning there's a fluid-filled cavity around these joints, and that just helps for protection and keeping your appendicular skeleton, giving that the ability to move with more range of motion. And then the functional classification of joints, a synarthrosis joint is a non-movable joint, like your skull bone articulation, so completely non-movable. An amphiarthrosis is a slightly movable joint. An example of this is between your vertebrae. And a diarthrosis is a freely movable joint. And an example of these will be your knee, elbow, and wrist articulations. If you can remember the word SAD, S-A-D, it'll help you remember the order of mobility of these functional classifications of joints. So S, synarthrosis, not movable, amphiarthrosis, slightly movable, and diarthrosis, freely movable, S-A-D, SAD, if that helps. Fontanelles and sutures, we talked a little bit about this last time. So this shows in a baby, in an infant skull, the sutures will develop when the bones of the skull come together. So sutures are just a type of fibrous syndesmosis joint, completely immovable. And up until 12 months of age, you might see a soft spot or a fontanelle, which is an area on the skull where the bones haven't completely fused together yet to form a suture. Structure of a synovial joint. So synovial joints are the fluid-filled cavities. So this is most likely a look at your elbow or a knee, a simplified version. There will be tendons that help to attach bone to bone to keep everything nice and tight together. The joint capsule will have a synovial membrane, a fibrous part of the joint capsule. There will be bursa, which is extra tissue for protective purposes. There will be articular cartilage on the ends of the bones so that you're not rubbing bone on bone. There's a sort of a protective piece for the ends of the bones. And then the joint cavity itself will be filled with synovial fluid, which just helps to again reduce friction between the bones as they are very movable. In your knees, especially if you lose some of this articular cartilage, you could be rubbing your femur and your tibia right on top of each other, and that can be very painful. And usually a knee replacement goes in and tries to reinforce some sort of fake articular cartilage to try to reinforce that knee. Also will reinforce with stronger tendons. These are types of synovial joints. And I'll kind of let you guys look through this on your own. It tells you the type of the synovial joint and where it might be located in the body. A plane joint, a saddle joint, a hinge joint is in your elbow. Also your knee. Pivot joints, an example would be where your radius and ulna connect to each other. The ball and socket joints, where it will be in your hip and your shoulder. So these just give you examples of the types of synovial joints, how much movement is in each type, and examples of where they're located. the different types of movements then that you should be familiar with, because if you're going on into a healthcare field, or if you're not and you ever get injured, you will hear these words to describe how well you're able to move these joints. Physical therapists use these words probably hourly whenever they see a new patient, because they'll measure how far their joints or the bones can move using these movement description words. So flexion is bending, and extension is straightening. Abduction, so abducting is movement away from the midline. So as scary as it sounds, if you think of someone getting abducted, they're being taken away. So abduction is movement away from the midline. And adduction is movement back towards the midline. So adduction is adding a bone or a part of the body back to the midline. Pronation and supination is the movement having to do with your forearms. So if you were to move your forearm in pronation, it would be moving it so that your palms would be facing down, and supination would be rotating your forearm with your palms facing up. And sometimes I like to describe these really silly, and you can think of a different way to remember them, but pronating your forearms as if you're trying to pick up something. So pronating, picking something up with your palms down, and supination, rotating your forearms up as if you're trying to hold soup in your palms. So pronating, picking something up, and supination, rotating them up so you're holding like soups in like your bowls of your hands. Rotation itself is just movement of any structure along a long axis. So these are pictures of what I just described. So you can abduct your fingers if you spread them all apart. And adduction is putting them back together. Flexion and extension is shown here. Usually flexion and extension, flexion is always decreasing the angle between two body parts, and extension is increasing or straightening it. Flexion and extension of your arm, pronation and supination of your forearm, medial and lateral rotation. Medial rotation will be towards the midline, and laterally rotating will be taking something away. And then circumduction is a special type of rotation that kind of goes in any which direction. So those are types of movement. Questions about those?
Hey, Professor, why do doctors use mile? Every other word, like your arm could be falling off, and they're like mile, I don't know, some kind of bum name, problem.
Did you say mild? Where did
they always use the word mile.
Oh,
like,
mild.
Yeah.
So we just
even if your arm is falling off.
Well, maybe that's just to not scare their patient. I know, but I mean, mild, I would think they were using mild if it's something not that serious. But
It would make sense, right? But it is not the case.
Yeah, I don't, Julie, I'm guessing you have a personal story about your arm was falling off and the doctor just said it was mild, but I would assume that would be more serious. I don't know. That's a great question.
Yes. So whenever we do the VA physical exams and stuff like that for percentage, and then of course you have your records and things like that with the X-ray records and things. Even in the worst case, they call it mild. And then when you're looking at it and you're reading it, it's like it's not mild. It's a serious problem. That's why I'm here in the first place. That's why I was like, why do they always use mild?
Yeah, you should ask a doctor that, not me. But yeah, that's a great question, Ray. I don't know. You'd think they would have a different term for that, but good question.
Well, I'm doing medical terminology too right now, and I haven't heard of it yet. But
ask your instructor there then. Yeah,
she's horrible, and unfortunately, she's the only one that teaches the class in Crafton.
Okay. Well, okay. That'll be on recording now.
Oh, my bad.
That's okay. All right, let's finish up with this and then I'll stop the recording. The effects of aging on the skeletal system, and this is our last slide. There's decreased collagen production, and collagen is important for creating parts of your bones. There's loss of bone density, especially in females because of the hormonal changes that our bodies go through during menopause. There's a great loss of bone density, and that's called osteoporosis. Also, there are degenerative changes. So your bones can become brittle and have more holes in them. So those are just some of the effects of aging on the skeletal system. If you guys are really interested in this, go on and take anatomy and physiology, because anatomy is just fun, and learning the bones is extremely fun too. Sorry, I just stopped my video. I was trying to stop the recording.